Greetings and welcome to our CAP Today webinar today entitled Respiratory Pathogen Detection, an Outcome-Based Study on a First-In, First-Out Testing Algorithm. I'm Bob McGonigal. I'm the publisher of CAP Today, and I'll be serving as your moderator. And after our single formal presentation of today, I will be leading a question and answer and comment section at the end of this webinar. The webinar will be presented by Dr. Raquel Martinez of Geisinger, and I'll say more about her when I introduce her right before her speech. But first, I would like to thank BioFire. This webinar is made possible by a special educational grant from BioFire. And CAP Today, of course, does not endorse any products or services that we may name within, but we're very grateful for our educational sponsor. From the housekeeping point of view, you should all be listening to this webinar through your computer speakers. And if you wish at any time to ask a question or make a comment, you'll need to type that into the Q&A box, which is below the slides there. You can see that below the picture of Dr. Martinez. At the end of the session, as I said before, I'll be leading a question and answer session, and Dr. Martinez will be here to answer your questions and field your comments. I want everyone to understand that this webinar will be made available online at captoday.com. In approximately 10 days, you'll be able to hear all the audio and review all of the slides. And now, without any more ado, I'd like to introduce more specifically Dr. Raquel Martinez. She got her PhD from Dartmouth, and she's a diplomat of the American Board of Medical Microbiology. In the Department of Laboratory Medicine at Geisinger Health System, she is the Director of Clinical and Molecular Microbiology. She's a distinguished thought leader in this field, knowing not only the clinical condition, the pathogens, and the technology that she's going to discuss. And so it's my great pleasure to introduce Dr. Martinez. Dr. Martinez.
Thank you. I'd like to begin by thanking the organizers of this webinar for inviting me to speak to you about respiratory pathogen detection. I'm very pleased to share with you the work we have done utilizing a first-in, first-out testing algorithm for respiratory pathogen detection and the clinical impact that a rapid diagnosis can have on patient care. Next slide, please. We were awarded an investigator-initiated grant to fund the data extraction portion of the study that I'm going to share with you today. Next slide, please. We will begin by briefly reviewing the evolution of respiratory pathogen detection methodology. Next slide. We will then discuss different testing algorithms. Does how you test matter? We all know that not all assays are created equal. We also know that nucleic acid amplification tests are more accurate than antigen testing in viral culture, but which molecular assay should you choose? Moreover, who are you testing? Do you have better outcomes if you test in patients only? Or should all patients get the more expensive nucleic acid amplification test? Where you test also plays an important role in patient care. Should testing be performed near the patient, for example, in the emergency room or in an outpatient clinic? Or should the laboratory be the gatekeepers of test operations? Next slide, please. Once you implement your test of choice, does it matter when you perform testing? Do you screen with a rapid antigen first, or do you go straight to the molecular assay? And how does this impact your turnaround time? I will share with you a few mechanisms we have implemented here at Geisinger to improve our time to result. Next slide, please. I have thrown out a lot of questions regarding the how, when, where, and how to test, and unfortunately, I have more questions than I have answers. And part of the problem is that few of us have answers to these questions, in part due to the fact that the literature is lacking. There are very few studies that have been published to date on how testing for respiratory pathogens can impact patient outcomes. So with that, I will finish the presentation by sharing with you an outcome-based study conducted at Geisinger in which we investigated the role of a first-in, first-out testing algorithm on ICU patient care. Next slide. And then I'll share with you a sneak peek at our future direction. Next slide, please. As PCR and nucleic acid amplification tests evolve, the time to result decreases, making rapid results more easily attainable. From the time when traditional methods such as viral culture were the primary means to identify respiratory viruses, it could take several days before results were even available. And now, even with conventional PCR methods, those that require extraction prior to amplification, those assays can take several hours also. And with more rapid technology, instruments that allow for random access or sample to answer platforms, those provide results in about an hour. The utilization of a new technology such as flow cycling or isothermal nucleic acid amplification provide rapid molecular results in about 20 minutes. These assays are designed to be point-of-care tests. They provide results equal to the time it takes to perform a rapid antigen test. And this is huge, so I'm going to say it again. For the first time, we can obtain a molecular respiratory pathogen result in the same time as a rapid antigen test. But it's even better because we have results that are accurate. This is the best of both worlds. We have access to speed and accuracy. So now the real question becomes, how fast do the results need to be made available in order to make an impact on patient care? Next slide, please. Traditional methods such as culture, DFA, and rapid antigen assays are slow, laborious, or unreliable. We know that nucleic acid amplification tests are fast, they have better detection, and they can target multiple pathogens at once. There are lots of data to support that nucleic acid amplification tests are better than traditional methods. We know their performance characteristics of their assays. There's lots of literature on this. But what we don't know is how these rapid, more accurate results impact patient care. Do these assays help antimicrobial stewardship? Are patients getting less antimicrobials? Is the length of stay shorter because patients are getting therapy, targeted therapy sooner? And what does this mean for our overall healthcare costs? Next slide. But before we dive into how these assays impact patient care, we need to take a step back and ask, does how we test really matter? Next slide, please. We need to first consider utilizing some sort of testing algorithm. Which assay or assays do you choose for your laboratory? When do you test? Where are you testing? And who gets the test? We'll come back to these questions shortly. Next slide, please. First, I want to share with you some data that was posed earlier this year. There was a survey posted on ClinMicroNet listserv by Dr. Melissa Miller. For those of you unfamiliar with this listserv, its members are comprised of clinical microbiology laboratory directors, such as myself. The survey encompassed respiratory, multiplex, pathogen testing, and current testing practices. And I'll quickly highlight a few of the results here. The first question she asked was, which of the following diagnostic nucleic acid amplification tests do you perform? The assays listed both included commercially available tests and laboratory developed tests. Of 87 respondents, 333 assays were reported, which results in an average of about 4 assays utilized per laboratory. You can see nearly 80% of laboratories utilized an FDA-approved or CE-marked multiplex PCR assay. Multiplex PCR was defined as an assay that has greater than 5 targets. For those laboratories not performing a nucleic acid amplification test, cost was the #1 reason for not yet implementing. Next slide. Traditional methods, as I mentioned, such as culture, DFA, and rapid antigen assays, target a limited number of pathogens per assay, whereas multiplex panels are attractive options as they can detect up to 20 different targets depending on the assay. Multiplex panels are advantageous because it is difficult for clinicians to determine the cause of the respiratory infection. It's difficult to identify whether it's a bacterial or viral infection. And so thus we have the advent of syndromic testing. This allows us to test for a wide variety of pathogens driven by the patient's symptoms. Multiplex panels for respiratory infections allow us to definitively identify the pathogen, whether it's bacterial or viral, and this can aid in targeting therapy and hopefully limits the use of unnecessary antibiotics. Moreover, they also reduce the number of unnecessary laboratory tests that are ordered. They enable patient cohorting and also allow the collection of epidemiological information. Next slide, please. The next question we ask is, does when you test matter? In my mind, how and when you test feed into your institution's testing algorithm, whether it's called an algorithm or not. Next question, or next slide. We know why we want to test. We saw from the poll results that many people utilize a multiplex panel for respiratory virus testing, but how many use some sort of testing algorithm? Are you still using traditional methods in addition to your multiplex assay? Do you first screen with an antigen test prior to your PCR, or do you only perform the molecular assays? Do you batch your testing, or do you provide a non-batched testing algorithm, such as a first-in, first-out type scenario? Is the multiplex test used year-round, or do you only use it during flu season? Is testing limited to certain patient populations, or do all patients get the multiplex panel? What do you do for inpatients? What do you do for outpatients? Is this testing being performed at the point of impact, such as in the emergency room? So as you can see, there are many factors that feed into devising your own personal testing algorithm. Next slide, please. When asked, if you perform a molecular multiplex panel, which of the following tests are performed prior to testing by your panel? As you can see, 65% of respondents reported that there is no testing algorithm. There are a small percent of laboratories that perform rapid antigen testing and a variety of other methods prior to using their multiplex test. But the majority of laboratories do not utilize a testing algorithm. Next slide, please. Moreover, the majority of laboratories perform testing as specimens are received on a first-in, first-out basis. This was 53% of laboratories. Batch testing makes up 36% of responses, where testing is performed either once per day or multiple times per day. For the sites that perform testing on a first-in, first-out basis, it's unknown whether it is truly first-come, first-serve, or if there's some sort of triage system that is also in place. Next slide, please. 65% of respondents reported that anyone with an order can get the full multiplex respiratory panel. One question I'd like to raise is, should we be testing everyone? Testing everyone is certainly the more easy thing to do, but is it the right thing to do? We need to understand who really benefits from these tests and how they benefit. As a community, we need to understand the impact on patient care so that proper stewardship can be in place. If we combine the other responses, that gives us a total of 35% of respondents that have some sort of patient population limitation or targeted population that they utilize their multiplex panel for. What is interesting is that there are a few studies in the literature that show patient impact data, And there certainly aren't studies that look at each one of these specific patient populations listed here. There's a huge need for this data. So going one step further now, we're starting to learn of point-of-care studies in which testing is performed directly in the emergency room rather than in the laboratory. We know or we hypothesize that more rapid, accurate results are better for the patient, but we don't fully understand the true impact for all the different scenarios. Next slide, please. So just to recap what we've discussed thus far, we know that the majority of laboratories utilize a multiplex panel to identify respiratory pathogens. They do not follow a specific testing algorithm. Testing is not batched. It's performed on a first-in, first-out basis. And anyone can get the test. There are no limits to who is tested. So now I'm going to shift gears and tell you a little about us and our story here at Geisinger. Next slide, please. Geisinger Health System is an integrated healthcare network with 12 hospital campuses distributed over 45 counties in Pennsylvania and also now expands into New Jersey. The Geisinger Health System has grown substantially in the recent years. I've been here for just over 3 years, and during that time we have merged with 3 hospitals, and we're in the process of merging with 3 more, 2 of which are in New Jersey with the addition of AtlantiCare. Next slide, please. At Geisinger, we take a system approach to microbiology. Our primary goal is to standardize microbiology processes across our system, but we also take great care to integrate and personalize processes for every site because not all sites are the same. We have large tertiary and quaternary care hospitals, as well as several smaller community hospitals within our healthcare system. We do this through adopting best practices in microbiology with the goal of putting our patients first. Next slide, please. This is a recent example of standardizing microbiology services. Just as a background, I'll tell you that back in 2013, Geisinger Health System did away with rapid antigen testing for influenza due to the assay's low sensitivity. This is a difficult standard of care for newly acquired sites to adopt. They don't like giving up their rapid antigen tests. And last respiratory season, we integrated a new hospital into our health system. And this hospital, like many others that have integrated, was resisting our standard of care of not performing the rapid antigen assay for the detection of flu. So we made an agreement that they would still perform their rapid antigen test so long as they remembered to forward their negative specimens to us for a reflexive PCR test. So we wanted data and we needed data from their site to prove to them that the rapid antigen test is inferior to nucleic acid amplification tests. For this experiment, we observed a positivity rate of 17% determined by the antigen test, whereas we felt the actual positivity rate was 25% as performed by the PCR assay. Next slide, please. It was no surprise that the antigen test missed 38% of true positive influenza cases. This resulted in a 60% improvement in detecting influenza with the PCR assay compared to the antigen test. So needless to say, we no longer perform rapid antigen testing at any site in our healthcare system as part of our standard of care. Next slide, please. This is our respiratory pathogen testing algorithm. We have 2 testing platforms that we utilize in our healthcare system. Both platforms are closed systems in which only one specimen is tested at a time. Some call these sample to answer or random access platforms. One of the platforms supports a multiplex PCR and the other supports an abbreviated respiratory panel, which includes 3 targets: flu A, flu B, and RSV. We offer both tests during respiratory season. We define respiratory season as November 1st through April 30th of every year. Inpatients receive the full multiplex panel, whereas outpatients get the abbreviated flu A, flu B, and RSV panel. Testing is performed in the laboratory on a first in, first out basis with a twist. We have an additional triage that we'll discuss shortly. Next slide, please. This is our algorithm during non-respiratory season, which we define as May through October. We only offer the full respiratory panel during this time as the likelihood of flu is lower in these months. Next slide, please. We saw earlier that 65% of laboratories do not follow a specific testing algorithm for the detection of respiratory pathogens. As you now know, Geisinger Medical Laboratories does follow a specific testing algorithm, and we were recently asked how we maintain such an algorithm. Well, to be honest, it's because we're constantly educating our providers on the algorithm so that they make sure to order the test that will provide the most patient care impact. Any provider can order the full panel. We don't stop them from ordering it. We just don't recommend it if it's not going to impact patients' care. So at times, we function as laboratory stewards. We will directly follow up with providers who do not appear to be following the algorithm. This usually occurs at the beginning of every respiratory season, as every year we have, new residents and new providers that join the system that just need to be educated. And this mainly revolves around outpatient clinics. We need to remind those providers in outpatient clinics that they should be ordering the abbreviated flu RSV panel when flu is a predominant pathogen. We get very good compliance once we provide that direct education. We also link our testing algorithm to our test catalog, and we publish multiple reminders in our laboratory newsletter. Next slide, please. Here's a screenshot of our test catalog for our respiratory pathogen test. At the bottom, you can see a purple link. The user will click on the link and it'll take them directly to the testing algorithm that's in place at the time that I just showed you. Next slide, please. This is an example of our newsletter. This is sent out across our healthcare system. It goes out not only to our laboratory personnel, but it also goes out to providers, residents, students, as well as administrators from our health plan. Geisinger has their own health plan. We provide important information on test changes, laboratory updates, outbreak information, as well as circulating respiratory pathogen epidemiology during our respiratory season. Next slide, please. Here we have a screenshot of last year's respiratory season, again, which we define as November 1st through April 30th of every year. It's a bit hard to see, but on the x-axis are the CDC weeks. The number of each virus is plotted against the y-axis, and the different viruses are color-coded. So, for example, flu A is in the teal or aqua color, and you can see that we observed a large spike in flu A positive cases starting, it looks like, in CDC week 9. We'll revisit this slide and discuss how we use these real-time epidemiology results, how these results can be used not only to track the circulating pathogens in our area, but also how these data can be used to make operational decisions. Next slide, please. This graph represents the historical turnaround time data for respiratory pathogen detection in the Geisinger health system. Back in 2009, we performed traditional methods for the identification of respiratory pathogens, viral culture, DFA, etc. And you can see that our turnaround time was nearly 3 days. In 2011, we implemented the use of a batched molecular multiplex PCR assay. This assay, as I mentioned, was batched once a day, Monday through Friday. And by doing that, we decreased our turnaround time by nearly 30 hours. And then late in 2012, we implemented a non-batch platform, different assay, And we significantly reduced our turnaround to less than half a day. So this was a huge reduction. And since then, I alluded to the fact that the Geisinger health system has grown substantially over recent years. And we have not only maintained our turnaround time, but we continue to decrease it. So today you can see that our mean received to result time is 2.83 hours, and our median collect to result time is less than 2.5 hours here at Geisinger Medical Center. The system median for receive to result is basically 2 hours, and the median collect to result is 2.71 hours. Next slide, please. We are often asked how we can provide such a low turnaround time for respiratory pathogen detection, being such a large healthcare system. And one of the first ways we accomplish this is by placing testing platforms at each of our hospitals in the system. Depending on the size or volume of testing for each site, the number of instruments varies. But ultimately, every hospital performs their own testing. This serves to limit transport time. Specimens are not held up by unnecessary transport between hospitals to the core laboratory. Standardization of test menu is a major component for reducing turnaround time as we dramatically limit the transport. Next slide, please. This data is from a poster I presented at the Clinical Virology Symposium back in 2014. We had just placed instruments at one of our larger tertiary care sites. So naturally, we saw a dramatic decrease in their turnaround time as they began performing their own testing. More so, their turnaround time was even better than ours. We are listed as Hospital A. We are the core laboratory for the system. And our turnaround time was a bit higher because we not only test more specimens here, but we're also receiving specimens from all over our service area. But this was just a nice example how placing those instruments on their own campus allowed improvements in turnaround time. Next slide, please. Next, we offer a first-in, first-out testing basis. On top of the first-in, first-out, we incorporate a triage system which calls for testing critical patients first. Lastly, we have implemented several performance dashboards, which I'll show you within the next few slides. But first, I want to talk about our triage system. Next slide, please. Even though we have anywhere from 1 to 6 instruments per laboratory, throughput is an issue with our multiplex system because we use a closed system in which only one patient or one specimen can be run per instrument. We put into place a triage system to help reduce extended emergency wait times such that specimens coming from the ER get placed on the instruments first, followed by those that are coming from ICU, and followed by other inpatients, and then lastly we place outpatients on our multiplex platform, and that's because we don't recommend outpatients getting that test. On the right side is a diagram of our protocol for when we know there's going to be a significant delay in results. So this also feeds into our triage. Because we are limited by the number of instruments we have, throughput, as I mentioned, can be a problem. And so if a site predicts that results will be significantly delayed, then they can initiate our backlog protocol. And this basically means they send their backlog specimens to the reference laboratory, assuming that the reference laboratory can absorb that testing. And we do this because we strive to provide the same quality of results, the same turnaround time for all of our patients, regardless of their location within our healthcare system. Next slide, please. I mentioned we have multiple performance dashboards. These dashboards are part of a web-based application that we utilize. They're interfaced through our laboratory information system. It's basically a glorified data viewer. They're nice because they have easy access. It's just a website. The data is filterable, which allows us to personalize the data for each hospital or each clinic, what have you. Next slide, please. We have multiple dashboards that focus on our respiratory pathogen assays. One has just all the results. Another shows us which ones are pending, and another one just for turnaround time purposes and epidemiology purposes. So I'll kind of spend a little bit more time on each as we go through the next few slides. Next slide, please. We worked with the emergency room in the summer of 2015 to better our ER wait times. So one of the projects that we did was implement these dashboards. So there is a dashboard in the emergency room that allows them to view in real time when a respiratory test result has been released. So they know immediately that the result is there. They don't have to call us looking for it. And conversely, we placed a pending dashboard in the laboratory to help us see and triage the specimens coming through. In this effort, the main objective was to support our system initiative to reduce the ER wait time and improve bed management. Next slide, please. These are the metrics that are observed in our laboratory for respiratory testing. They include the collect to result time, which is the time the specimen was collected to the final result. Collect to delivery time, the time it took to get from the emergency room to the laboratory, and the receive to result time, when the laboratory actually received the specimen to the time that it was resulted in our laboratory information system or in the electronic medical record. Next slide, please. Here is a screenshot of the ER dashboard. It's very hard to see, but it basically lists the patient and whether the result was positive or negative. You can see the yellow highlighted one, it says positive. The person in the ER can click on that, and then it would expand into, which targets were positive. Does the patient have flu A or does it have coronavirus? These results are available in real time from our laboratory information system. It's accessible from any computer in the ER or any computer, basically, because it's a web-based application. And these results refresh every 10 minutes. Next slide, please. So conversely, we have a pending dashboard in the laboratory which complements the ER dashboard as well as helps with our triage system. So as you can see, the dashboard is color-coded. ER specimens are in green. Blue are special care or ICU sites. Black are inpatients. Our test catalog states that our turnaround time is anywhere from 2 to 8 hours, but as I just showed you, our turnaround time is really somewhere around 2 to 3 hours. So you see items highlighted in red. Those are the ones that are above what we set as our internal threshold for turnaround time. Anything greater than 3 hours for an inpatient will turn red, and anything greater than 7 hours for an outpatient will turn red. So this dashboard allows the technologist to easily identify which specimens have priority, or if any specimen is lagging, they can quickly investigate why. Maybe we lost a specimen, what happened to it? I can tell you that the specimen highlighted in red in this example is from one of our outpatient clinics. So I hypothesize that it's probably delayed in transport there. So prior to our dashboard, a result could be delayed anywhere from 24 to 48 hours or even more before a technologist was aware that a specimen was still pending. And that's because it would show up on their pending report that they would do every morning. But sometimes they didn't show up on the report, and we would see turnaround times of like 1,000 minutes. So the specimens, now with the pending dashboard, it allows for a faster response time to investigate, why is the specimen still pending, and thus ultimately this is improving our turnaround time and our workflow. Next slide, please. As I mentioned, we implemented the dashboards last summer. And when we first went live in our hospital, which is listed as GMC for Geisinger Medical Center, A few months later, we implemented a similar dashboard for our community hospital in Scranton, labeled on the graph as GCMC for Geisinger Community Medical Center. As you can see, the receive to result time prior to dashboard implementation was about 3 hours for both sites. However, the dashboard implementation, after the implementation, the receive to result time significantly decreased by 1 hour at GMC. And you can see a reduction in the receive to result time in Scranton, but due to the fact that they didn't have their dashboard as long as we did, you can't really appreciate a significant decrease. Perhaps they just need a little more time to see that same effect. But nevertheless, the receive to result time is reduced after we implemented the dashboard. Next slide. Moreover, since the goal of this joint effort was to reduce wait times in the emergency room, of course, we next wanted to know if our dashboards were doing what we hoped they would. On the left, you can see that the emergency room wait time was 193 minutes prior to dashboard implementation, and it decreased to 169 minutes after implementation. Not statistically significant, but trending in the right direction. Similarly, the graph on the right shows that the time for when an admit order was placed to the time that the patient actually arrived in the unit also decreased. Prior to implementation, wait time was 140 minutes, and it dropped to 117 minutes. Again, not statistically significant, but trending in the right direction. Next slide, please. This data comes from another dashboard that not only tracks our epidemiology, but also provides turnaround time, test per tech for our workload volumes, and our overall test volumes. This slide illustrates how knowing our epidemiology in real time allowed us to make a real-time operational decision. Last year, flu season came to us a little late, and as we approach April 30th of every year, we normally start preparing to change our testing algorithm from our two-pronged algorithm to only offering the full respiratory panel, and thus continuing our abbreviated flu RSV assay until the following season. However, because we could see that there was still a fair amount of flu B circulating around April 30th, you see the bars in purple, that was flu B. There's still a lot of flu B in our area, so we decided to extend our outpatient testing for a little longer until we saw it drop off. So this was extended a few more weeks. And we did this because it's a patient dissatisfier for outpatients when they have to pay the larger bill for the full multiplex panel, especially when it's not needed. Next slide, please. Now we come back to our turnaround time data. I want to remind you that 2015 was a particularly bad season as the vaccine miss led to more cases of flu. Our sample volume increased over 50% that year. And what's cool is that we, again, not only managed to maintain our turnaround time, but we actually decreased it. And since last year, we have acquired more instruments at every hospital site, and we're doing even better. This year in 2016, you can see these are our best turnaround times yet. So where do we go from here? Next slide, please. As I've shown you, Geisinger has a lot of performance data revolving around respiratory pathogen detection, but we're lacking outcome data. We know we have an outstanding turnaround time, but so what? Does it matter? Are we truly providing the best care we can for our patients? With so many unanswered questions, we decided to evaluate the downstream outcomes to truly assess the impact our respiratory pathogen results had on our patients. Next slide, please. This just outlines our study design. I'll remind you that in 2012, we implemented our non-batched multiplex respiratory assay. This was a quasi-experimental or pre- and post-intervention study design. We included patients that received the multiplex results the 2 years post-implementation and patients that received traditional or batched molecular results the 2 years prior to implementation. We focused strictly on ICU patients as we wanted to know how we were affecting our most critical patients. Our study was age, gender, morbidity, and DRG matched. Below are listed the data variables that we included in our study: ICU days, emergency room length of stay, overall length of stay, antimicrobial utilization, 28-day mortality, ventilator days, total cost, and test utilization. Next slide, please. Our pre- and post-intervention group show similar data distributions. We saw no significant differences in the distributions of viruses in our two groups. We also observed similar positivity rates for the two groups. Next slide. For those patients that were admitted to the ICU via the emergency room, we saw a reduction in time spent in the ER. The pre-intervention group spent 6.2 hours in the emergency room, while the post-intervention group spent a significant less amount of time, 1.4 hours less to be exact. Similarly, we saw a significant reduction in the number of ICU days. The pre-intervention group was in the ICU for about 9 days, whereas the post-intervention group only spent 6 days in the ICU, so 3 days less. Next slide, please. When we looked at anti-infectives, we observed a significant decrease in the number of antiviral days for the post-intervention group, as seen on the left. We see a reduction of 0.6 days compared to the pre-intervention group. And on the right, we see a similar trend. The number of antibiotic days was significantly decreased. The pre-intervention group received approximately 9 days of antibiotics, whereas the post-intervention group only received 7 days of antibiotics, which is a 2-day savings. Next slide. But more importantly, from the study, we show a significant reduction in the mean length of stay and increased survival for those patients in the post-intervention group. On the left, the mean length of stay in the pre-intervention group was 14 days. Meanwhile, those in the post-intervention group only stayed in the hospital for 12 days. And on the right, the percent fatality in the pre-intervention group was 80%, compared to 73% fatality in the post-intervention group. The relative difference here is a 10% decrease, which is huge. Next slide, please. As you would expect from our results, the reductions we observed also equated to a savings in total healthcare costs. There was value added not only for samples that tested positive, but also for samples that tested negative. For positive samples, we saved approximately $9,000 per visit, and we saved about $8,000 per visit for negative results. This saved our system a net savings of approximately $4 million. Next slide, please. So going back to one of my earlier questions, I asked, how fast do results need to be reported in order to make an impact on patient care? As part of our study, we were curious to know if there was a magic number, and if so, what is it? Next slide. On the right, you can see by comparison that the collect-to-result times are dramatically reduced for the post-intervention group. Both the 90th and 50th percentile of the pre-intervention groups are in the magnitude of days, whereas the post-intervention groups, the collect-to-result times are just a few hours for both categories. Unfortunately, we did not observe a linear correlation between the collect-to-result time and survival. However, when the combined collect-to-result time was substratified, the percent fatality at 28 days significantly decreased for patients who in the post-intervention group when results were delivered in less than 7 hours. So in other words, survival increased when results were provided within 7 hours. And this can be an important finding for those that still batch testing. As we saw in the beginning of the talk, 30% of laboratories are still batching their tests. If the batch can be performed such that the majority of the results are available within 7 hours, perhaps they'd also see an increase in survival as well. However, those studies would need to be performed as we don't know the true answer to that. Next slide. So moving forward and looking to the future, we're now focusing our efforts on assessing the impact of rapid respiratory pathogen detection in an outpatient setting. We just launched what we are calling FluWorks. Our urgent care clinics are called CareWorks. So our project of providing direct flu testing in our outpatient clinics took on the name FluWorks. We placed instruments in select regional clinics. They are large outpatient community practice clinics with laboratory services. So now with FluWorks, those specimens will be tested on-site rather than being couriered here to our reference laboratory for testing. This will, in no doubt, reduce the collect-to-result time for those patients. And our goal is to have the results and prescription available in about an hour. So today, our testing algorithm has an added arm to its complexity. A patient will present with an influenza-like illness. If they're an inpatient or a patient in the emergency room that is likely to be admitted, they will get a full multiplex panel, whereas outpatients will get the abbreviated flu RSV assay. Next slide, please. As part of Geisinger's transparency initiative, we hope to have these results immediately released into our patient portal where patients can access their chart notes and laboratory results, among other things. In the center, we have an image of the website called My Geisinger that patients log in to see their results. And on the left, we have an image of my phone where I have my app open, where I can access test results and appointments and other things. So we hope to have this, our results linked through the My Geisinger and have them linked to pharmacy orders. So for example, if the patient tests positive for flu, they will get their results along with the prescription for Tamiflu. Or if perhaps if the patient tests negative, then their prescription will be canceled and the patient will get a lovely message, you know, with some sort of antimicrobial stewardship note as to why they don't need antivirals or antibiotics. Next slide, please. So we know that proximity and speed are trending. We're starting to hear about point of care and point of impact testing. There are many advantages, as you can see from those listed here on the slide. However, next slide, there's also a very long list of challenges that we will face as we move forward towards this point of impact testing. Next slide. So in conclusion, we know that rapid and accurate results improve patient care. I hope I've shown you that a first in, first out testing algorithm can improve your turnaround time as well as your survival. And we think that results within 7 hours have the potential to positively impact patient care. With that, I'd like to acknowledge my colleagues here at Geisinger, especially Dr. Donna Wolk, and the medical technologists without whom we could not do this work. Their hard work and dedication for providing these rapid and accurate results is much appreciated. They're a wonderful team to work with, and many thanks to them all. We also like to thank our data analytics team who helped us to analyze this large data set for our study. And before we go to questions, I'd just like to end with our CDC PSA here. Remember to take through 3, get your flu vaccine, wash your hands, and if you get flu, remember to get your antivirals early. And with that, I'll take any questions. Thank you.
Dr. Martinez, thank you very, very much for a splendid lecture. That's a very rich overview of your activities, and it's very easy to see why, after this presentation, this is one of all the many things that are done at Geisinger that make the system so very widely admired. So you have our congratulations. I'm going to let you get a chance to catch your breath here before we begin our questions and our comments. Let me remind you, if you'd like to make a comment or ask a question, you can tap that into the Q&A box that you see there below Raquel's picture. And also, if you want to review this presentation, both slides and audio, we'll have that available in approximately 10 days on captodayonline.com. So we've got plenty of questions here, as I figured we would. There's several that are all coming along, really talking about tips or the process by which you're educating your many, many clinicians about your new protocols. Could you address that for us quite briefly?
Sure. We send, before flu season, we always take a look at our algorithm and revise it if needed. And we send a message through our, electronic medical record. All clinicians have to go into, we use Epic here, to the chart, and so they can get their inbox message to remind them that, the testing algorithm is going live for respiratory season. That's one way all providers get that message. As I mentioned, another way, we provide the algorithm in the test catalog, so that information is easily accessible. We also send out a newsletter from the microbiology laboratory reminding clinicians of the test changes, because we do turn off and turn on tests as needed. And so we just try to really, really push out there the information for them to know of the algorithm. And as I mentioned, if it seems like we're getting a lot of tests from a certain clinician in an outpatient clinic, we can call that person up and ask them to please, make themselves familiar with our algorithm if they're not.
Thank you very much. We've got quite a number of questions regarding the dashboard and essentially the IT connection. So first, can you tell us what your LIS is at Geisinger?
Sure, we use Sunquest here.
They are a Sunquest shop. And tell me about the technology that's behind the dashboard. I know you have a wonderful data analytics group that you pictured there. Is that a middleware product, or is some of that designed yourselves at Geisinger in interface with your Sunquest system? Tell us a little bit about that.
It's a product called AltoSoft. So it's something that you can purchase. Like you mentioned, it's a middleware. It connects interfaces through the LIS. And it's a web-based application, and it's nice because it can pull data, as often as a minute, I believe. So it just pulls the information from the LIS depending on what you need it for. And our entire laboratory uses it for, turnaround time monitors and that sort of thing, both in anatomic pathology and clinical pathology.
Yes. If I may just mention, I had the great privilege of visiting Geisinger a little over a year ago, and the metrics that they have and display in real time throughout that laboratory, it's absolutely stunning. It's very, very impressive, and I know there's a big team that does that. We've had several questions a little bit about your discussion of mortality pre- and post-implementation of your algorithm. Could you reiterate those results and also talk a little bit about this impact on the ICU length of stay and essentially a disposition of ICU patients? Of course, that's a very big concern both as a clinical matter and as a logistical and financial matter for systems.
Right. So as I mentioned in the beginning, we did look at the DRGs for the patients included in the study. So primarily they, had been admitted for sepsis or respiratory failure, and that was common in both groups. So when we looked at 28-day mortality, did the patient survive or not? I don't know that there's much to really say except for that the numbers showed that there was a significant decrease when we had the non-batched results available to those patients.
Very good, thank you. And we've had several questions. Obviously, we're only about 5 weeks or less than 5 weeks. How is the flu season going for you at Geisinger and in your geographical area to date?
So far, so good. We're not in the thick of it yet. I can pull up our dashboard and tell you exactly where we're at, but we don't really concern ourselves with our patients following the algorithm so strictly, until we really see that flu and RSV are the predominant pathogens circulating in our area. But like I said, we're still okay.
Very good. Thank you very much. I just wanted to mention again the middleware that Raquel mentioned was Alto software. Very easy to find anywhere on the internet if you just go into Google. I think that's true, isn't it, Raquel?
Yes, very easy.
Very good. And let me ask you yet one more question about the geographical reach that you're involved in. I mean, I know that you cover a huge geography, and so it's going to be very important that the specimens that do come in from the wide-ranging system into your lab there are of high quality. Has this new protocol or this new algorithm helped improve the quality of specimen collection for individual patients?
That's a tough question. I mean, you know,
Yes.
we without really looking at the data, but I mean, I don't think we've seen a difference in our positivity rate or anything like that. We looked at that for our study, and those were very similar. Yeah, I think that's a hard thing to say based on just the algorithm. I mean, we try to educate on specimen collection as well. We have best practice teams that, you know, focus on different areas of the laboratory, microbiology being one, specimen collection another. So we really try to get, you know, higher level people involved in these conversations so that education goes out across the system.
Very good. Thank you very much. Now, as you seek to distribute more and more instruments within the system, how many current sites have this technology on site?
I'd have to count them all. Let's see.
Okay.
1, 2, 3, 4.
All right.
Like 7, I think.
Okay. And
Yeah.
if you have your
that's not including our. Well, that's only including the multiplex.
I got you.
As I mentioned, in some of the outpatient clinics, we have 8 sites where we just placed our abbreviated panel instrument there.
Okay. And tell us again, what is that abbreviated panel?
We use the Cepheid Gene Expert.
Using a gene expert there in those sites.
Yes.
Now, I'm assuming that some of your clinicians and certainly your pharmacists have to be looking forward to looking at the results and the benefits for antibiotic stewardship by establishing testing in these urgent care outpatient clinics. Is that going to be a subject of study? Absolutely.
I mean, when we first presented this data to our antimicrobial stewardship team, which is encompassed by microbiology, infectious disease, and pharmacy, there was some controversy as to the utility of these assays, in outpatients for the multiplex test at least. So I think it'll be interesting to look because now we have both scenarios available where we have, patients that are getting the multiplex tests from outpatient clinics, and then also the ones that have the abbreviated panel right in the outpatient clinic themselves. So that's our next study, and we're very excited to look at that data.
Yes, thank you very much. Thank you. We've got several questions regarding what are the full range of respiratory pathogens that are covered within the multiplex panel. You had one slide, I think, where you showed those.
So what BioFire detects? Is that the question?
Yes, in the BioFire multiplex panel.
Not off the top of my head. I know that. I don't know if Beth is on, but we have, flu A, flu B. We have H1N1, different coronaviruses, different parainfluenza viruses, human metapneumovirus. Right. There are a few bacterial pathogens such as Chlamydiophila, Mycoplasma, to name a few. Bordetella. Yep.
Yeah. Bordetella. Thank you very much. For those who are interested, I'm sure it will be very easy, should you wish to have a BioFire representative describe that full panel to you at your convenience. So that should be an easy question to follow up on and to answer.
Yes.
So let me just ask one or two more questions. This constant physician education, that's obviously something that's ongoing and a continual kind of loop. As you set up the outpatient settings for urgent care, is there a change really in the tone or the need there, or is it kind of more of the same in terms of your education, sitting down with people explaining what you're looking for in terms of what they do in those settings?
Are you talking about the sites that have the testing within the outpatient clinic themselves?
Yes, exactly.
Well, really, I think that would be a little bit easier because those are contained units, and so those ordering physicians would know that it would make better sense to order the abbreviated panel because that result will be given to them within that hour because the testing is on site there. If they decide that, if they really do need that full multiplex panel because, that patient is at higher risk for other respiratory pathogens, then there would be a delay because then that specimen would have to wait for the courier and get here. So that adds, time to the result. But if they really only care, does my patient have flu or not, then it makes more sense for them to choose the test that's on site.
Right.
And
do you anticipate
they'll get that?
Do you anticipate then that's going to have a very positive impact on the actual day-to-day work that you'll be doing?
Oh,
in your
absolutely.
reference lab? Okay.
Yeah, it won't only improve, our patient care goal, but it'll help relieve some of the workload that comes to us from those sites.
Very good. I want to thank you very, very much. And I see that we're about at the top of the hour here. I know there's many questions, and we're going to try to follow up with those as best we can. But I'm being mindful of all of your time. And so with that, I want to give my hearty thanks to Dr. Raquel Martinez. We're getting wonderful, wonderful comments and congratulations on the excellence of your presentation, Dr. Martinez. So I hope you can bask in the glow of that. And as well, let me remind everyone that her slides and her lecture will be presented in full, including our questions that we've gotten to here, in about 10 days at captodayonline.com. We'll post that, and we will keep that up for about 1 year, so you'll have plenty of time to look at that. And so now I want to once again thank Dr. Raquel Martinez of Geisinger and her colleagues there. It was a wonderful, wonderful lecture. I'd also like to thank BioFire for their educational sponsorship. And I would like to thank each and every one of you for taking your time out of a busy day to join us here. I do feel I should mention that today is the 75th anniversary of Pearl Harbor. I'm aware of that and hope that we can all have a moment of remembrance about that important event in history. And with that, once again, thanks to all. We look forward to having webinars in the new year. For those of you interested in this particular area, we'll be talking about community-acquired C. diff in a February webinar, and we'll be looking at hemophilia monitoring in a webinar in about the middle of January. So both of those will be wonderful programs along with today's. So once again, thanks to all and good day.